Thanks, James. So it's quite interesting. Of all the people involved in this session, Shingai doesn't sit still. Steve can barely hang on to anything there, and I'm going to walk around the whole time. So good luck. You guys are going to get dizzy. The last fellow didn't even pitch. That's how far away he is. Okay. So it's going to be, how should I say, a session that moves around a bit. So I thought the easiest way to do this, because it's quite a large topic, we can kind of do it guideline-driven. And I mean, I'm not a fan of guidelines. I think for all the stuff we do, there's enough data. So guidelines are not strictly speaking necessary. But there's a lot of our colleagues that need a paint-by-numbers approach. And for mere mortals, guidelines work. Okay. Shingai, just for you, I'll put a different picture, just to keep it real. And I managed to crop out the cartoon stock from the center, Steve. Like, really, you should try harder. Okay. Okay, so I'm a medical oncologist in private practice, and I work in Gauteng. And for some reason, we have a larger access to an array of therapies in Gauteng, probably to do with the kind of patients we see and the level of insurance that they have. So we kind of have a bigger array of things that we have to throw at them. I mean, Shingai and I regularly argue at the meeting in the morning where he says, that's too expensive, what's the benefit? And I said, have you seen how much that building costs to keep the lights on every day? They pay 30 million per month to rent the building. Don't tell me this is too expensive. Right, so it's all relative, right? It depends which pond you fish in. There's no AI that assisted with this talk, which is quite sad, so it'll be at a relatively low level. Okay, so in terms of what we're trying to get out of this, it's basically what are the therapies you're going to select for bladder cancer, and it's got a little bit of what non-muscle invasive and muscle invasive bladder cancer. And then what you're going to do to monitor patients while they're on therapy, chemotherapy, and all of that. So what's the initial therapy, okay? So stage 2 disease, you have a choice of things you can do, okay? You can go a neoadjuvant strategy, and a neoadjuvant strategy should be a cisplatin-based neoadjuvant strategy and not a carboplatin-based. Okay, so there's enough data in this disease entity that shows that carbo is actually inferior to cis. So as a rule, like, don't be scared. Check the kidney function. It's not difficult, just read what Lancet writes in the bottom. And then the next part is calculate how much you're going to need. And if they can take it, it's not a bad thing to give them, okay? And as we mentioned earlier, a cystectomy is going to happen in this disease. What kind is when you're going to argue, and on top of that, when you're going to do it. Okay, because patients' quality of life is significantly impaired if you just whip out their bladder at the first sitting. So it's about trying to make sure that you can kick that bucket down further down the road without impacting on patient outcomes. And I think that's where our trick lies. How do we just try and stretch that elastic as long as possible? Then there's neoadjuvant cisplatin-based therapies with partial cystectomies in some patients. If patients won't be able to tolerate cisplatin chemotherapy, then you kind of sometimes have to go to cystectomy. And then bladder preservation strategies can happen with concurrent chemotherapy. And then you can radiate some of them if you can't do any of that. In a 3A, it's much the same. And then remember, once you do that, there are adjuvant strategies that are available. And those adjuvant strategies include chemotherapy. It includes immunotherapy, and in some patients, radiotherapy. Okay, so towards the end of last year, this is what everybody kind of did, right? In terms of current guidelines, okay? You started off for the non-invasive with intravesical therapies. Then you moved on to other kinds of immunotherapies with or without PD-1 inhibitors. And then in the muscle invasive, you would, for most people, take on a neoadjuvant chemotherapy strategy prior to an operative intervention, okay? And those neoadjuvant strategies is MVAC-based, cisgem-based, or, as per Niagara, carbogem with durva, okay? Now, if you look at the latest data, you will see that prognostic biomarkers are an integral part of that process. So they're looking at ctDNA as predictive of who's going to respond better. So there you go, Shingai. We're already starting to delineate who are the people that we need to go harder with and who are the people perhaps that it's not worth it. Okay, whatever worth it means. Okay, and then at the end of that, after you've done the cystectomy, then you need to consider some kind of adjuvant therapy, depending on whether it's node positive or not, depending on what you've done, and very importantly, depending on what you've given them up front. So if you've given them neoadjuvant therapy, you're now going to give them different stuff in adjuvant, a maintenance type strategy. And that's what's happening. Here, all the chemo radiation trials for muscle-invasive bladder cancer, okay? And you can see there's quite a lot of them. They've been around for a long time, and it's an integral part of the armamentarium in these patients. Now, I know lots of you are scared of radiotherapy in the bladder, and Steve regularly regales us with horror stories of what the bladder's like after it's been radiated. But we've kind of converted him. We've done a few, and he survived. Steve survived. Okay, and that is the problem, right, Jeff? It's to get Steve to survive. Patient's fine, but Steve battles. Okay, so here's one of them, a 10-year follow-up, phase 3, BC2001, and they use mitomycin radiotherapy versus radiotherapy alone, high-risk patients, and you can see in terms of local regional control and OS, there is a difference. Okay, you can see the plethora of patients, you can see the spread of patients in terms of stage, and you can see in essence that the patients did okay. Okay, please notice the radiation doses, and they're not nothing, right? They're a decent-sized dose. Okay, so therefore, it is established, it works. Okay, so what's new in the field? Okay, so let's start with neoadjuvant therapy. So one of the things you will see is that we are trying to incorporate immunotherapy in the whole neoadjuvant space, okay? Now, historically, the entire bladder field was divided into cisplatin-eligible and cisplatin-ineligible, okay? And it's related to basically how well the kidneys are working, because cisplatin is a wonderful drug. The only problem is you go deaf afterwards, your kidneys take strain afterwards, and sometimes you lose the feelings on your fingers and toes. So it's important to dose this thing properly, okay? It's also important to ask the patients how they feel, literally. Okay, simple things. Can you sign your checks? Although we don't use checks anymore, okay? Can you do your buttons? Can you lift up a cup of tea? So all those things. Now, if they can't do that, you missed the boat. You should have found out earlier. Because the problem with platinum and cisplatin is to reverse that problem is hard. Remember, all these patients need to go and get their hearing done before we start, because it's a bit difficult to manage once they've got severe ototoxicity. So these are the things we have to manage. So we're looking at a combination in the neoadjuvant, IO and novel, or IO and chemo, versus placebo and chemo, and in the adjuvant also IO or IO and novel. And you can see on the right-hand side of that slide all the different trials. Okay, some of them have already been read out, but that's basically what you would be looking at, cisplatin eligible. And then in the cisplatin ineligible, we can use IO. Well, we're investigating the use of IO. Why? Because in terms of IO use in this field, IO being immunotherapy, okay? IO use in this field is easier for us. Why? Because they have different toxicities. They don't have the same toxicities, they have different toxicities. So you need to know what to look for. You need to know how to manage these patients. But certainly, for patients getting immunotherapies, I don't have to worry about the kidneys as much. Okay, it doesn't cause those kind of problems. And providing you know how to manage it and what to look for, and providing the patients have an easy access if they have problems, this is a kinder therapy. Less hair loss, usually. Okay, so one of the developments of the field is Niagara, the Durva plus neoadjuvant chemotherapy in patients with operable bladder cancer. Okay, and you can see they were randomized to durva cisgem versus cisgem with durva afterwards. Okay, and I agree with Shingai, like with many other maintenance IO strategies, we're not sure about afterwards how much bang for your buck you get from the maintenance IO. And that's where all the big money gets spent. However, without doubt, we know that adding the IO to the chemotherapy doublet makes a difference. If it didn't, those curves wouldn't have separated, and not statistically so. Okay, so here's one little jump we have made in the neoadjuvant space to change the needle a little bit in terms of how these patients will do. Of course, as always, funding is an issue, cost is an issue, and managing these patients become a little bit more tricky. But you get confident with these things and you learn how to use it. What about adjuvant therapies following cystectomy? Well, we've had a few game changers in the field. One of them has been adjuvant IO. And Nivo, I think, was the first one in the space that showed that if you give adjuvant nivolumab for a year, you do get a survival benefit. And you can see there, it's in the intention to treat population that there is a survival benefit. And very interestingly, you don't even need to be significantly PD-L1 positive. Anything over 1 is good enough. And it's probably to do with a bladder being a hotter tumor than other tumors. Okay? So in the IO field, you have cold tumors and hot tumors. So a hot tumor would be like a melanoma, an immunogenic tumor. A colder tumor will be like a luminal breast cancer, slow growing without lots of antigenic expression. So therefore, in luminal breast tumors, IO is not a big thing. But in a melanoma, you don't even have to test to give them immunotherapy. Immunotherapy is a game changer. Okay, so that's probably why. Remember, there are toxicities. The commonest things we have to put up with when we treat patients with immunotherapy is a rash. Okay, now, you would think that's nothing big, but for patients getting therapies for a long time, rash is a big issue. Okay, so the rash is easy to manage. You just find a friendly dermatologist. Okay, very important, because everybody gives them a UA base with a little bit of cortisone in it. That's going to buy you so much time. Then you're going to throw a little bit of prednisone at them. Because if you give them more than 10 milligrams a day, then why are you giving them IO? Okay, because IO is an immune stimulant, and the prednisone is an immune depressant. So how are you going 2 steps forward and 10 steps back? Okay, so it's just an important concept for people to understand. Don't go and give large doses of prednisone when you're giving somebody immunotherapy. Okay, and I'm using prednisone as a cortisone, not necessarily that you need to use prednisone per se. Okay, so that's something to understand. So when FDA gave Nivo approval in 2021, which is quite interesting because for us, we still don't have Nivo, which is a whole different reason. We do and we don't. There were things to be assessed. There's benefits and there's risks. The benefits are actually these molecules are well tolerated. They do seem to numerically push out your OS, okay? And they do prevent disease recurrence. But don't be confused. Every now and then, I get a patient after 1 dose of IO that goes into liver failure. And liver failure is not nice. You tend to go a bit yellow, okay? The second thing is there's financial toxicity here. These are not cheap things. Immunotherapy is roughly between 80 to 120 a dose. And you're going to need 1 dose every 3 to 6 weeks, depending on the schedule, or every 2 to 4 weeks, depending on the schedule. So it's expensive therapies. So you need to have a hard and fast indication before putting them on these therapies. Okay, and they have to come and see you every 3 weeks or every 6 weeks, depending on what schedule you put up. And not all of us want to see our patients all the time. You guys are lucky. You get to cut their bladders out and send them away. We have to see them regularly. So managing these kind of things is an ongoing challenge. Okay, so adjuvant Pembro is also improves the outcome in these patients, okay? And they're 18 cycles, that's 1 year. Fixed dose pembrolizumab, which is another bugbear of mine, so I won't bring that up, but there's good data, you can fiddle the dose, so let me not say that, but it's a scientific meeting, and there's nobody here that's going to stand up and say, I'm talking off label, but you can play with that, and you can make the rand go further if you know how to do it. Okay, so in these patients, we see again, although there's no OS benefit, there certainly is disease-free survival benefit. So that's why if you're going to choose between the two, with this, you would rather choose the Nivo rather than the Pembro. Okay, so what about adjuvant therapies today? Cisplatin-based, if no previous platinum-based neoadjuvant therapy. Adjuvant Nivo for patients who've had neoadjuvant chemo. Pembro is something you can think about, but the last one is the best option. If you've got a clinical trial, which we always kind of have running around, it's best to put them on for the biggest reason. The IO is for free then. Okay, and that's one of the reasons we have a plethora of clinical trials at any one time, is because we have that ridiculous situation that many of the funders don't pay for even good outcomes therapy. So one of the ways we get around that is you have a robust clinical trial program, and you choose the trials based on what the best is in the control arm, because at very worst, they get standard of care. There's also novel therapies with fancy drug delivery systems. Then you look at TAR, that is fancy gemcitabine, together with sertrillimab, which is another PD-1. Okay? So these are all the new trials that you will wait, that will come out quite soon, that will give us interesting outcomes. So what's the current recommendations? Okay? First line, you can see there, we should be giving people, whether they platinum eligible or platinum ineligible, they should be getting enfortumab vedotin plus pembro. That is level 1 evidence. It exists, there is benefit. Of course, that puts a real difficult problem in front of us. The first one is not yet registered in the country, so none of the medical aids have to pay for it. Secondly, it probably costs more than the second drug on that thing, so it makes it very difficult to use. So I think I've used the one thing once, and we don't get to be able to give these to patients. Then we'll end up having to do a gem-cis strategy or a gem-cis-nivo strategy, and then we try and stay from dose-dense MVAC, because we all have been traumatized by MVAC. So we all got PTSD. Okay, MVAC is hectic. Okay, so you need cojones of steel to use MVAC. So we try to steer away from that. Okay? Atezo, interestingly enough, was registered and then not registered because there's no OS benefit. Okay, so atezo is a little bit difficult. So in some patients, you can consider atezo, but you can see category of recommendation is 2B. So it's not category 1. Right, so it's not that robust in terms of data. This here is subsequent line and second line, okay? And you can see here, basically what you're going to use is whatever you didn't use up front, okay? The problem is in bladder, there's only certain lines of therapy you're going to be able to give them. The backbone of therapy is platinum-based with gemcitabine. You're sometimes going to have to be able to get biomarker-directed therapy, and I'll go through that now to show you when that will happen. And then, if you're lucky, you may get to use a taxane. But that's almost the sum total of everything you're going to have to you can use. There were, well, like the enfortumab vedotin, there are drug-antibody conjugates in this field, okay? And you should only use them. They're not first line, they're second and third line. And SC, which is sacituzumab govitecan, the data has also been withdrawn there because they're not that robust. So this was before ESMO 23, where they still had things as platinum sensitive and platinum ineligible. Now, it's pembro plus enfortumab vedotin, okay? And that's first line. And you can see on the subsequent lines, sacituzumab govitecan has been kind of taken away because A, it's how should I put this? It's a little bit difficult to use. Patients take a bit of strain. They get tired. They drop their counts. And remember, that is chemotherapy. It is chemotherapy with all the side effects of chemotherapy. It's just as a fancy drug delivery system. And that fancy drug delivery system is the mAb. So it's chemotherapy stuck to a monoclonal antibody. So the monoclonal antibody takes it to where it need to be given, and you're still going to get all the side effects of chemotherapy. And if you're going to use these drug antibody conjugates, you must, A, give them decent anti-nausea therapy. So they should be treated like HEC. For those of you who don't know what HEC is, it's a highly emetogenic chemotherapy. Okay, so you should be giving them triple therapy in terms of antiemetics. Okay, so it's important not to go light on the emetics because you think, nah, don't worry, this is only a monoclonal antibody. It's not. Okay, so what does the guidelines look like? You can see there, unlike before, it's now first line, enfortumab plus pembro, and then if they're not eligible, we're going to use a platinum-based therapy with maintenance avelumab. Okay, and then if they're not eligible for platinum, you might want to give them carbo, if you can get away with it, with gemcitabine. Unfortunately, you will see there are other drugs. The other drugs to be used in the metastatic setting requires a biotherapy-directed, a biomarker-directed approach. Okay, so we know it's quite simple. First line, if it's not available, it's very easy. We then decide whether they're going to get an immunotherapy agent or whether they're going to get the other agents that are available. Okay, and we will use these other agents if they've not yet been exposed to them in their entire treatment cascade. Okay, so our options are platinum-based therapy, MVAC. In the second line, we either switch, thereafter we continue the avelumab as a maintenance, or a second-line immunotherapy agent. If at that point they then relapse, we at that point have the chance to give them the enfortumab. However, at that point you need to do genomic testing, because the genomic testing will tell you if you're going to need the FGFR3 inhibitor. Okay, so whether you're going to need datanib or not, and you need to check their HER2 status, because that's going to tell you whether you're going to need TDXT, and then there's all those other agents which is good to use on a clinical trial. So why are we looking at that? Well, we know that there is evidence for the combination of nivo plus cisgem in metastatic urothelial, and nivo cisgem with the nivo maintenance afterwards is associated with OS and PFS benefit. So the nivo pushes up the cost tremendously, but you can see at the end of the day, there is OS benefit. So because there's OS benefit, these patients are going to live longer. It's worth giving them that. You can see there that the number of patients that are well and alive is much, much higher than standard chemotherapy. So if you can offer these things to the patients, it is something to seriously consider. Is it safe? Yeah. The addition of nivo to the cis-gem combination doesn't appreciably increase the side effect profile. So for the most part, there are some side effects that are related to the immunotherapy, but for the most part, it's actually well tolerated. This is the basis for which enfortumab and pembro became standard of care. Okay, you can see they're locally advanced or metastatic, no prior systemic therapy. They were randomized to the doublet versus the doublet of previous times versus enfortumab pembro, and you can see the curves are widely disparate. So there is a real survival benefit, which means this should be new standard of care when it's available and when it's funded. Okay, and you can see that there are a few side effects that are specific to these drugs. There's side effects there. Those side effects are usually specific to the IO, and then those side effects are specific to the enfortumab vedotin, the drug antibody conjugate. Okay, and again, you get skin, you get peripheral neuropathy, and you get eye disorders. There's one other thing to mention, just before I stop talking about, I'll get to that. Okay, as I said, the SC has been withdrawn because the Tropics 4 came back as didn't meet their primary endpoint. So now in the latest guidelines, SC has been taken off as an end line. The interesting thing in bladder is bladder does express HER2 in about 12% of patients. So if you've got a HER2 expression, these are ideal candidates for trastuzumab deruxtecan. Not something that's easy to say after a few glasses of wine, but certainly early in the day, it's easy to manage. Okay, and it's even, as long as you got HER2 expression, you can use this agent with very good success. Is there basis for it? Yes, in bladder cancer, they use single agent TDXT, and you can see there that there are responses for those kind of patients, okay? Usually in these things, you can see that forest plot shows you in terms of all the patients with bladder cancer that were exposed to TDXT who were HER2 positive, the majority of the patients responded. So if you've got HER2 disease, that's what you do. Okay, so there's the current expert opinion on the treatment landscape. So we should do the doublet, the DAC and the IO, or the ADC and the IO. If you can't do that, you're going to do a cis combination, and then give them a maintenance IO. And then when they recur, you're going to have to give them, look for biomarker-directed therapy, and that'll be looking for HER2. It'll looking for FGFR3. And then you make your choices on that. And then if you're really lucky and you've got a decent clinical trials program, that's where you can put them. These are the ongoing trials in the field. If you could get them enrolled in one of these, you would benefit the patient, and it's worth looking for them because all of them have IO or enfortumab as the backbone. So they're going to get better than what you can give them under your clinical circumstances. And I don't know if I saved you time, but thank you.